Hello, everyone. Welcome to today's webinar, an overview of the Foundational Public Health Services. On behalf of FAB and our Center for Innovation, we're really happy that you were able to join us today. I'm Melissa Seaver. I'm a Senior Advisor for Public Health Systems and Services here at FAB. And we have several presenters with us today, including my colleague, Naomi Rich. She'll be speaking in just a moment about the Foundational Public Health Services model. And then we're really excited to have three guest speakers representing Minnesota, Wisconsin, and Oregon. And they're here to share a little bit about how they're using the Foundational Public Health Service model for their system improvement and transformation initiatives. And I'll introduce each of them as they take the floor to present. So a few quick housekeeping items before we get started. We do have a very large group today. I think we had over 200 registrants, and so we will keep microphones muted throughout our time together. But we do encourage you to use the chat to introduce yourselves, to interact with one another, the speakers, each other, and then also ask that you use the chat for questions as well. And we do have several FAB staff who are monitoring the chat, and we'll be able to answer those questions maybe in the moment, but we'll be certain to leave some time at the end for Q&A as well. The session is also being recorded and may be posted on the website, and we'll be sure to send you a link to the recording, as well as a copy of the slides and an evaluation after the end of the webinar. And then lastly, if you encounter any technical issues, we would encourage you to chat to Lydia. If you're our colleague Lydia, our guy who's keeping monitoring the chat for us, if you have any technical issues, please feel free, if you can chat, to put it there. If you have significant issues, we just encourage you to log off and then log back on. And if for some reason as hosts we lose our connection, we'll follow up with everyone via email. So this slide that is on the screen now shows the topics for today. We have a lot to get through, but our hope is that by the end of our time together, you'll be able to describe the Foundational Public Health Service framework and its role in systems transformation, that you'll be able to give 3 examples of FPHS implementation in the field, and that you'll be able to list some FAB tools and resources that are available to support you and your public health systems in your system transformation efforts. And then before we jump into content, we do want to ask a really quick polling question. I know as part of the registration, we asked about familiarity with the Foundational Public Health Service model. But Lydia, if you could put up the question, is your health department and/or health department system using the FPHS to guide infrastructure improvement and transformation efforts? So yes, no, or unsure. We'll give just a few more seconds. I think about half of folks have responded. So about half, it looks like, have or are using the framework, which is fantastic. A few of you are unsure, about a third, and then about 15% of you are not. So that's good to know. I think I would encourage those of you who are using the framework to please share how you're doing that in the chat. And for those of you who aren't or are unsure, hopefully you're inspired by our time together today. All right, so with that, I'm going to go ahead and turn it over to Naomi, and she's going to provide a high-level overview of the Foundational Public Health Service framework. Naomi, the floor is yours.
Thanks so much, Melissa, and thank you everyone for joining us today. The FAB Center for Innovation has been the steward of the Foundational Public Health Services since 2016. The FPHS have been and continue to be driven by the field, and that's something really important as we move forward in this work, that it reflects your work. I'm going to share a brief overview of how the FPHS came to be, and then provide an introduction to each component before passing it back to Melissa. The history of the FPHS starts with a 2012 recommendation from the Institute of Medicine report for the public's health, investing in a healthier future. The recommendation was to create a minimum package of services. This refers to the suite of skills, programs, and activities that must be available in state and local health departments everywhere for the public health system to work anywhere, and also one for which costs can be estimated. To explore this recommendation further, the Public Health Leadership Forum in spring 2013 was funded by the Robert Wood Johnson Foundation and facilitated by Resolve, convened, and the resulting product was a conceptual framework, which we now call the FPHS, that outlines the unique responsibilities of governmental public health and defines a minimum set of foundational capabilities and foundational areas that must be available in every community. It also includes additional non-foundational items, what we call community-specific services in the framework, that describe the additionally important work that is delivered every day by governmental public health. Since FAB became steward of the FPHS, we have been working with state systems and health departments to implement the framework through our 21st century learning community, which started with 3 states who were focused on adopting the FPHS within their context. We have also embedded the FPHS in version 2022 of the FAB standards and measures and for accreditation and our Pathways program. So let's do a quick review of the framework. The FPHS framework outlines the foundational and unique responsibilities of governmental public health. The role governmental public health plays in the delivery of services may be different agency by agency or community by community, state system by state system. But it always consists of these 3 main components: the foundational capabilities, foundational areas, and community-specific services. The framework was most recently updated in 2022 based on discussions at the national level, lessons learned from the pandemic in 21 C states, and to better integrate equity across all of the FPHS. Together, the foundational capabilities and foundational areas help us define the minimum package of services that governmental public health must provide in all communities. It's really important to view the FPHS through a systems lens rather than just an agency lens to ensure that services are provided to all community members and through an approach that thinks about equity, effectiveness, and efficiency. Service delivery can be done through the state system, through a single health department, or collaboration with neighboring jurisdictions through regional models or other partners. We have seen the framework used by governmental public health systems to guide their transformation planning efforts, estimate capacity and costs, and identify gaps, as well as communicate to decision makers, advocate for change, implement strategies to build a public health workforce and other capabilities and areas, and more. As you learn more about the framework today and how it can be used in the following slides, we encourage you to take the time to think about how the FPHS can be used to benefit the work of your system. The components that we will explore are made up of work that your public health department is often already doing. Through assessment, your public health system can better recognize strengths and where improvements can be made. I'll now break down each component. I encourage you to add specific questions or work you're doing related to the FPHS in the chat. Here we have the foundational capabilities. These are the cross-cutting skills and capacities needed to support basic public health promotions, programs, and activities key to ensuring community health, well-being, and achieving equitable outcomes. Health departments serve their communities 24/7 and require a strong public health infrastructure to access a wide range of critical data sources, robust laboratory capacity, preparedness and policy planning capacity, partnerships with community, and expert staff to leverage them in support of public health outcomes. These 8 capabilities create the foundation of the infrastructure, just as they are the foundation of the graphic. Examples of foundational capabilities that you may already be doing include, but are not limited to, prioritizing and responding to data requests and translating data information into information and reports, educating the public on important public health issues through social media and other communication channels, engaging members of the public and multi-sector partners in community health improvement planning and implementation, and integrating social determinants of health and actions to address inequities into all plans, programs, and services. Again, these are just a few examples of what foundational capabilities can look like in your community. Next, we have the foundational areas, which are also referred to as programs. These are the basic public health topic-specific programs basic public health, topic-specific programs and services aimed at improving the health of the community. The foundational areas reflect the minimum level of service that should be available in all communities. I'll note here the emphasis on all communities, whereas on the next slide, which we'll talk about community-specific services that are equally important, are based on a jurisdiction's needs and may not be necessary in all communities. Examples of activities that fall within the foundational areas that you may already be doing include, but are not limited to, inspecting and licensing healthcare facilities, coordinating and integrating categorically funded chronic diseases and injury prevention programs and services, identifying and investigating outbreaks and other efforts of public health significance, and protecting workers and the public from chemical and radiation. The last component is community-specific services. These are local protections and services that are unique to the needs of a community. These services are essential to that community's health and vary by jurisdiction. Services that may show up here are not considered foundational because they may not be needed in all communities. As mentioned before, this does not make them more or less important than the foundational areas or foundational capabilities. They are just not considered to be part of the minimum package. Examples of community-specific services may include direct clinical services, oral health, alcohol and drug treatment programs, or home health, but are not specifically outlined in the framework as they are not foundational to every community. The public health system must serve everyone and requires intentionality to embed equity in our work. Equity is cross-cutting and should be considered across all foundational capabilities, foundational areas, and community-specific services. Equity is also one of the 8 foundational capabilities, a necessary part of the public health infrastructure. I'll now turn it back to Melissa to talk about the FPHS framework's role and value in system transformation.
Thank you for that overview, Naomi. Before we talk about the role and value of the foundational public health service framework in systems transformation, I want to touch just briefly on the distinction between the 10 essential public health services and the foundational public health service framework, as we often get questions related to this. There are some similarities, but both were developed for different reasons and different purposes. So the 10 essential public health services are the broad public health services that should be available in a community, and delivery of those 10 essential public health services is the responsibility of not only governmental public health, but also all of our system partners. And so for those of you who've been in the field for a while, like myself, you may remember the jelly bean chart that showed all the system partners of public health. And so it is the role, again, of governmental public health, but all of our system partners to deliver on those 10 essential public health services. And governmental public health plays a role, certainly not only as a contributor to the delivery of those services, but also can serve as the convener or the chief health strategist in convening system partners to ensure availability of those broad services within a community. And then as Naomi shared, the foundational public health services are specific to governmental health department and health department systems, with the foundational capabilities and foundational areas considered to be that core package of public health services that should be provided by all governmental public health departments and systems to all people. And we also know that those foundational activities can also be costed out. So the foundational public health services play an important role in infrastructure improvement and system transformation efforts, and this slide shows a sampling of that. So first, the framework helps to create consistency across health department and health department systems. Some may argue in this country we have no real public health system. I think at minimum, we can all agree that it's certainly decentralized nationally, and also within some states. And so the foundational capabilities and foundational areas really establish that consistent, defined minimum package of services. That consistency then also provides us with common language, which helps us communicate about the work of governmental public health, which can be particularly important not only within amongst our own colleagues, but with our stakeholders, legislators, and others who may not be as familiar with the work and the role of governmental public health. Also, having a national framework, we're able to assess the cost and the capacity that's associated with the implementation of the foundational activities, those foundational areas and capabilities. That assessment then also allows us to uncover gaps, and then we can also then compare and benchmark across health departments and health department systems. And this becomes particularly important as we are thinking about advocating for sustainable government public health funding, both locally and nationally. And then we also know that our recent federal infrastructure investments are being tied directly to this framework as well. Most recently, the Public Health Infrastructure Grant, with Strategy A2 providing funding directly to strengthen the foundational capabilities. So this framework also serves as the foundation and the starting point for system transformation efforts. Next slide, please. And this slide reflects the approach to systems transformation based on what we have learned in working with states that have been engaged in intentional work in this space. And the process really starts with developing and defining a vision of the ideal future that you want to see for your governmental public health system. And then the system needs to adopt and define those core services. And this is where the foundational public health service model comes into play. From there, then, you assess your current state and identify gaps in resources, both capacity and cost. Once you have that information, then you can look at pursuing sustainable funding to support infrastructure. And then you can also then identify and test solutions to address those gaps, leveraging innovation as well. So as you can see, it really becomes a systems level CQI process. So with that, I want to talk a little bit about how this framework is being implemented across in several states. And so we want to share some work that's happening in Wisconsin and Minnesota and Oregon. All three states are members of FAB's 21st Century Learning Community, which is a peer learning group currently comprised of 18 member states, all of whom are actively engaged in intentional system level transformation efforts. And each of these states are in a little bit of a different point in their transformation journey. Some have been engaged longer than others. And we hope that these examples show how the transformation is often an iterative process that progresses over time. So they'll each spend about 5 or 6 minutes providing a high-level overview of their current work. So first up, I'm happy to introduce Kim Milbrath from the state of Minnesota. Kim is the director of the Center for Public Health Practice at the Minnesota Department of Health, and she'll share how Minnesota transitioned from a state-based set of public health standards to the national foundational public health service model, and how that the model is informing their innovation and transformation efforts. So Kim, the floor is yours.
Great. Thank you so much, Melissa. Good afternoon, everybody. I'm going to tell you a little bit about how we both started with adaptation of the framework and then moved to adoption of the national framework. But first, I want to give you just go to the next slide, please. A quick glimpse of what our system looks like in Minnesota. We are a partnership. We have state level government, local level government with community health boards, and then tribal governments. Each has its own authorities and responsibilities, and we work together to provide public health to the state of Minnesota. The before times. I think everybody knows what I mean when I say that. So we started this work a year or two before COVID happened. At that time, there were fewer states that were doing the work, that we had no hindsight from COVID, and equity was just becoming an emerging issue. And so we really felt we needed to take the main framework and adapt it to our context in Minnesota. One of the things you don't see on here, but you'll hear me say, is that we don't call it foundational public health services. We call it foundational public health responsibilities, because in our state, services really focused on the direct service of individuals, and we're trying to get people to think a step higher at the system level for population. So next slide, please. So we started this before COVID happened. We came out of COVID and we were trying to dig the framework out of the dustbins. But at that time, the state legislature was very interested in figuring out how to help shore up this public health system in Minnesota. So we received, before we were even really ready to reconvene, money to test new ways to do service delivery. So we have 16 or 16 or 14, I can't remember now, grantees who are working across the state, testing new service delivery models, all based around the foundational public health capabilities that were really the most challenging ones through COVID. Next slide, please. So as I said, we started all this before we even really had our strategic leadership team put together. So as we were lifting up these grants, we were also forming our joint leadership team. And the joint leadership team is made up of the leadership of the local Public Health Association of Minnesota, our statewide community health advisory committee, which advises the commissioner, their local elected community health board members who advise the commissioner on local public health, and then the Department of Health. And that group really has been the group that's been providing the strategic guidance, the vision, and we know, honestly, that one of them can't do it without all the others. So we're really trying to make this a collaborative and co-created process. Next slide, please. So when we got the funding for the innovation projects, we also got some additional funding to do some assessment. We just completed our cost and capacity assessment. We also are engaging in a system assessment. So we're kind of getting the financial side and the staffing side from the cost and capacity and capacity side. And with our system assessment, we're really looking at the practice and the policies. How do we do public health in Minnesota? How are we structured? Do we follow the structure, the legal structure that we're supposed to? How are people getting around that? So looking at that, we also are really interested in trying to message local or public health in general in a way that is more relevant and understandable for the public. So we are doing some message research that will allow us to have a consistent message around the value of public health and why the system needs to be changed. And then you'll hear that we took another look at the foundational public health responsibilities, kind of dusted that off and started thinking about, is this still the same framework that's going to help us? Next slide, please. So the final piece of the work that we started right after COVID was also starting to work with tribal governments to determine how tribal governments want to think about infrastructure development. So we are contracting with an indigenous-led contractor to work with tribes. We also have a health systems consultant within my center that also is dedicated to tribes to help them think about, well, what do you guys want to do? Does this framework make sense for you? How do you want to assess your own work? And as just a reminder, tribes are all sovereign governments. So they each of the 11 tribes that we have in Minnesota has their own public health system. Next slide, please. So we've done all of this work. It gets us up to present day, almost a couple months ago, actually. And we felt it was time to reconsider the framework. One of the things that we really liked about moving to the national framework was that equity was called out both as something that's interwoven in its own individual capability. There's a great emphasis on that. We wanted to be able to align with national efforts and compare with other states. I talked to Sarah quite a bit. And I will be honest, it didn't come without tension. There was things that we changed how we called them in the Minnesota framework that people liked and they didn't like as much in the national framework. So we do have some tension with language and terminology that we are continuing to work through. And we are currently aligning the definitions and the activities that we defined with our Minnesota framework to the definitions and activities of the national framework. And we will get settled on that piece, we hope, in the near future. But so we did in Minnesota a little adaptation, and we've moved now to full adoption of the National Public Health Responsibilities Framework. And we think it's the right move for us right at this time. And that's all I have for you.
Thank you so much, Kim, for sharing the great work that's happening in Minnesota. Next up is Joan Thur from Wisconsin. Joan is a former local health director at the Marathon County Health Department and currently works for the Wisconsin Association of Local Health Departments and Boards. And Wisconsin is currently implementing the FPHS capacity and cost assessment tool at the local and state level. And so Joan's going to share a little bit about that process, as well as the challenges and opportunities that work is presenting in Wisconsin. So Joan, I'll turn it over to you.
Thank you, Melissa. Wisconsin's story is a seize the opportunity, building the plane, so to speak, while flying it. Planning for the assessment began in earnest during the summer of 2022, and funds then from CDC Public Health Infrastructure Grant enabled us to launch the assessment within a year of initial planning efforts. This assessment is one of 3 statewide assessments that will be occurring to inform us of the gaps as well as the opportunities to further modernize Wisconsin's public health system. The assessment will also provide a snapshot of our current local and state health department resources, its capabilities, and then what further investments will be needed to achieve full implementation of the FPHS framework. Next slide. Wisconsin's assessment is being carried out on 2 parallel tracks, having our state Wisconsin Association of Local Health Departments and Boards, referred to as WALDAB, leading the local department assessment, and then our state Wisconsin Department of Health Services Division of Public Health leading the state assessment. Through a contract from the state, WALDAB secured services from Reed Group out of Oregon to conduct the assessment for local health departments and provide collaborative services to the state. I'm pleased to share that 78 of our 85 local health departments completed the assessment, representing 95% of Wisconsin's population. Additionally, we have one of our 11 tribal health agencies that submitted. Data validation has been completed, and we are in the process now of analyzing the local data. Next week on November 6th and 7th, a meeting will be held with health officers and state representatives, as well as key partners, to review the analysis, discuss implications, and begin generating reports. Our goal is to have one comprehensive report by late spring of 2024, so as to inform legislative asks for the next biennial cycle. Over the next 6 to 9 months, Wisconsin will develop a communication plan to include strategies for building bipartisan support for further investments. As part of that communication plan, WALDAB is in the process of securing a vendor who will develop messaging as to benefits of investing in Wisconsin health departments. Next slide. As shared earlier, Wisconsin's experience is seizing the opportunity, avoiding the trap of analysis paralysis, that is, waiting until all the planning pieces are in place. So you can imagine some of the challenges we faced taking this approach. First one I just want to highlight is we had limited time to test the tool and seek consensus among users. The tool was released in March, and we began already our efforts in April. And to minimize this challenge, we recruited local health departments to participate in Wave 1, and their role was to test the tool, identify training needs and gaps in resources before launching statewide. Another challenge was agreement on what are community-specific services, needing to address the perception that community-specific services are of equal value as foundational capabilities and areas. In Wisconsin, similar to states across the United States, we have well over 50% of our health officers new in their role over the past 3 years, and with staff vacancies and turnover. And a way to minimize that challenge was to have Reed provide group and one-on-one TA. Another challenge is aspects of the tool were found not relevant for some of our state functions. Future challenges as we begin producing a report with recommendations is creating one statewide comprehensive report, having alignment with local and state report features. And the last challenge will be to build bipartisan support given Wisconsin state legislators' orientation towards small government. Assets we have that we've leveraged include the local health departments who stepped up to be in wave one and being instrumental in creating credibility of our ask. Wisconsin also was fortunate that our administrative rule 140 required services of local health departments was revised in 2019 and incorporated aspects of foundational public health services. Having a vendor like Reed Group with prior experience in doing costing and capacity assessments has been key to our success, along with a leadership planning team to guide the process. Another crucial asset is having a trusted association executive director who has been a consistent voice of encouragement for our local health departments and health officers. Frequent ongoing communication through weekly email updates, as well as utilizing WALDAB's bi-monthly health officer forums, have been instrumental. And lastly, our continued commitment to furthering local and state partnerships, wanting to continue to leverage resources and having a unified voice as to the value of investing in public health for Wisconsin. Thank you.
Thank you so much, Joan, and congrats on all the good work that's happening in Wisconsin and for being an early adopter, along with, I know, Minnesota as well, with the capacity and cost assessment. So next up is Sarah Boudreau. Sarah is the Strategic Initiatives Manager at the Oregon Health Authority in the Office of the State Public Health Director. And Oregon is actually one of our first 21st century learning community states and has been engaged in intentional system transformation efforts for, I think, almost up to 10 years now since your first report came out. So Sarah will be sharing more about the recent evaluation of their modernization and transformation efforts to date. And she'll also share a little bit about plans for local and state modernization strategic planning. So Sarah, the floor is yours. Thank you.
Great. Thank you so much. Hi, everyone. And also kudos to Kim and Joan. I love hearing you talk about the work happening in your states, and I always learn so much. So to start, Oregon Health Authority has a strategic goal to eliminate health inequities in the state by 2030. And our public health modernization work really is one of the key ways that the governmental public health system advances toward eliminating health inequities. So at a very high level, public health modernization for us ensures that every Oregonian deserves work starts from a place of every person in Oregon deserves access to the same public health protections through the governmental public health system. Also from recognition that the public health issues we're facing today are increasingly complex and cannot be met if we're still relying on a public health system that we built 50, 60, 70 years ago. And then finally, modernization. We're working to ensure that we have sustainable funding so that we have a strong, robust, well-skilled governmental public health workforce in the state to address those challenges. So next slide. I won't talk about this in detail, but Oregon is many years at this point into our public health modernization work. Across the top of this graphic shows the actions that our legislature has taken since 2013. They have put public health modernization in our state statute, so it is the framework for governmental public health that we need to be working toward. And the legislature has been providing funding to support that work since 2017 with increased investments each biennium since then. So our assessment and planning work really started back in 2015 with some specific things in statute that we were required to do. That's when we first did a system-wide governmental public health assessment and costed out what it would take to be able to fully implement our public health modernization model here in Oregon. And we have continued to use those findings in all of our work, in all of our funding requests, basically as the structure for how we move forward with modernization since then. At this point in 2023, we are receiving about $112 million for the biennium Those funds go out to federally recognized tribes, to Oregon's amazing 33 local public health authorities. And we also use a portion of funds to fund community-based organizations directly. Community-based organizations do not do the work of governmental public health, but governmental public health really can't reach our equity goals without working daily with the partners that provide culturally specific interventions to their communities. So to talk a little bit about our current evaluation on the next slide. We've been evaluating our work since 2015 or 2017, but the evaluation that we're just wrapping up now for the past biennium has by far been our most rigorous, and it really is showing the ways that our system is changing, and some of the gaps and recommendations coming. Some of our gaps that we still experience, and then recommendations for moving forward. So broadly, our evaluation looks at two domains, one around those foundational public health capabilities and showing how we're advancing in those capabilities because our state public health authority, local public health authorities, and community-based organizations are working together and in alignment. And then the second domain is around our public health workforce. So how has our workforce changed, and what are we able to do that we were not able to do before public health modernization? And this is just a snapshot of the types of changes we're seeing. Every local public health authority is implementing new communicable disease prevention programs, really focusing on the greatest needs within their communities. And then those next two items really showcase the work of how public health is working with community-based organizations and how community-based organizations reach people who need to be most connected with governmental public health. So you can see there the vast majority of our community partners are providing services in languages other than English. And when we experienced the MPOX cases a year or two ago, we were able to build upon those relationships we already had with community partners to immediately reach people who most needed to be reached with interventions and vaccine. Next slide. So also just a little bit about how the funding supports our public health workforce. So in the past biennium, more than 300 positions were funded in local public health authorities through the legislative investments. And you can see the types of positions being funded. In all, 69% of local public health authorities have hired new positions for foundational capabilities. So positions whose work crosses over all of the program areas, whether that be communications specialists, epidemiologists, community outreach workers, people who focus on policy. That's really new capacity we're building in our system. See, I think I have 2 more slides. And we use metrics to really demonstrate that we are improving outcomes for people in Oregon through our public health modernization work and the funding that's connected to it. So this shows the health outcome indicators we're working toward in this biennium. The thing that you don't see on this slide are the related process measures that describe the daily work of the state public health authority and local public health authorities to contribute to these health outcome improvements. So, one of the areas where we use those process measures to identify areas where we know we have gaps and to be working toward trying to fill them. So one example would be around data and epidemiology. So behind these different outcome measures, we're monitoring whether we're able to have the capacity to look at the data and to identify which populations need to be focused on in our communities, and then to make sure that our decisions line up with being able to better serve those communities. And my last slide just shows a little bit about what's coming. We have two new statewide deliverables that we're responsible for in this 2-year period. One is to develop a statewide public health equity framework for the public health system, and the other is to develop a statewide public health workforce plan. So really working toward that 2030 goal and recognizing that the public health workforce is at the heart of all of this. So being able to know where our gaps are and work toward filling those gaps. Local public health authorities, and the second item, are beginning to work on a deliverable they have due in 2025, which is to develop local modernization plans for their own jurisdiction. And as a part of that, we're in early stages of talking about what will it look like to update or redo the assessment that we originally did back in 2015 to see where we've made improvements and where our gaps still are. We'll be continuing to focus on implementing those public health accountability metrics to really be able to demonstrate that with, almost a decade of work and significant legislative investments, that we are making a difference in people's lives. And then finally, ongoing evaluation to show how those improvements are occurring in our system and to keep building off of them. Thank you very much.
Thank you very much, Sarah. Greatly appreciated. And I know there's some questions coming into the chat for all of you. Feel free to take a moment to respond if you'd like to in the chat, but we'll also leave some time at the end if you want to provide more context and discussion. So before we jump into Q&A, I want to talk just briefly about some FAB tools and resources that we have available that can support health departments and health department systems in their system transformation efforts. So this first slide, if you could advance, please. Oh, go back. There we go. Thank you. This slide shows a subset of what we refer to as our tools for transformation. And we have more located on our website, which I believe Lydia will put the link to our tools for transformation webpage in the chat. But I wanted to call out a few that are directly related to the FPHS model and implementation of the FPHS. So the first is our FPHS planning guide. And this is a really great place to start. If you're not sure where you want to get started, you want to know a little bit more, the planning guide, again, is a really good place to start. But it includes the key components that a health department or a health department system should be considering as they're planning for FPHS implementation. So if you think back to the slide that I showed about setting a vision, adopting a model, it kind of walks health departments and health department systems through that process and some of the key considerations. We also then have 3 different assessment tools, which you'll see in the 3 middle boxes on the slide. The first is our public health workforce calculator. And this tool allows local health departments to estimate the number of full-time equivalents that they need to provide the foundational capabilities and the foundational areas. And the calculator is specific to local health departments in decentralized systems with a population of under 500,000, just because the back-end data that's used to create those estimates and to do those calculations is based off of local health departments of that size and structure. So we hope as more data comes in through our capacity and cost assessment work that we'll be able to expand the audience for the calculator. And please know that if you don't fall into that sort of target audience, just know that you can still use the calculator. You just have to be just know going in that the estimates might be slightly off if your jurisdiction's larger than that. The next assessment tool that we have is the Foundational Public Health Services Capacity and Cost Assessment. We've talked quite a bit about that. We can put a link to the tool itself in the chat if that's helpful. But the capacity and cost assessment is designed for either individual health departments, although we encourage systems to complete it, so all local and state health departments together. And the purpose really of that capacity and cost assessment as Joan talked about as well, is to understand the current capacity and cost to deliver on the foundational capabilities and the foundational areas, but then also then to estimate the capacity and cost for full implementation. So where are their strengths, and then where also are there gaps, which can inform your planning efforts as well as any potential funding asks as well. And then we also have our accreditation readiness assessment. This is designed for individual health departments, and it helps a health department assess their readiness to apply either for initial accreditation or pathways. And I just want to mention very quickly that within the full standards and measures for accreditation, 34 of the standards and measures, so 34 of the over 100 that are part of full accreditation, are specific to the foundational capabilities. And that really underlies our pathways recognition program as well. So that readiness assessment can also be a way for you to assess the extent to which you're meeting the standards and measures related to the foundational capabilities. And then the last resource that you see here in that far right box, I just wanted to mention that some resources that we have related to service and resource sharing, because service and resource sharing can be a solution to gaps in capacity and cost that might be uncovered through the assessments that I just mentioned. So the resources are designed really to assist health departments and health department systems in setting up service sharing arrangements to ensure that the foundational activities are being implemented in all communities within their system. And again, really, for more information about these tools and resources, you can click on the link in the chat. I think it's also on the slide. So when you get a copy of the slides, you'll be able to link there as well. Also on our website, just real quickly, we do have a Tools for Transformation selection matrix that is intended to help health departments and health department systems select the best tool for transformation based on their need or the outcome that they're trying to achieve. And you can also just contact FAB as well, and I'll be sharing our contact information in just a moment. Next slide. So I also quickly want to mention before we jump into Q&A that FAB does provide the Center for Innovation technical assistance and consultation services. And so this slide shows a sampling of what we can offer, training, virtual, in-person. We do have some self-study modules specific to the Foundational Public Health Service, one for boards of health, and another module that we're currently in the process of updating that will be released soon that is sort of an FPHS 101 that's available for self-study. But we can also provide other virtual and in-person training. We can customize that training as well based on the needs of your state or your system. We can provide guidance on adopting and using the framework. We can provide support for the tools for transformation that I just mentioned, help with the capacity and cost assessment, the workforce calculator, et cetera. We also offer meeting design and facilitation services. So if you are meeting with your state system partners and want to talk through an agenda and processes, or even have an external neutral facilitator, we can serve in that role as well. And then just generally exploratory conversations around where your interests are, where your needs are, and what resources we may have available to support. So again, not a full list, but just gives you some sense of the types of TA and consultation services that we can provide. And I think the easiest thing to do if you think you might be interested is to just reach out to us. If you're a FIG grantee and it's in support of your FIG work plan, you can submit a TA request in 5, or you can also just email our general inbox at info@fabboard.org, and someone from our team will respond. But we'd be happy to have a conversation with you about one or more of what we've just shared from a tool and resource perspective. So with that, I want to turn it over to our Q&A. We've got about 10 minutes. So I'm looking over at our questions here to see maybe what has already been answered. I may not be following so well, so if you feel like it's already been answered in the chat to my colleagues and presenters, please let me know. So this is for Sarah. The assessment that you described, is it available in a document? And did you reply to that already? I'm sorry.
I did. I put the link in the the chat. You can go to our public health modernization webpage and you'll see all of our past documents and reports.
Perfect. Perfect. And then I see, Sarah, you also responded to the question about accountability metrics, that you're happy to share those as well.
Yes, absolutely happy to share them. I also put in the chat, we are actually just finalizing those. So they are like way too messy to be posted publicly. But if anyone wants to, like publicly on our website, but if anyone wants to email me and sort of get a sneak peek of what we're working on, I'm happy to share it. And otherwise, it will be all publicly posted in December.
Thank you, Sarah. So Kim, I know I see you responding as well in the chat, but one of the questions is from someone in Minnesota, the local public health level tasked with educating around the foundational public health system. Will MDH or the UMN School of Public Health be releasing an education plan?
Yeah, it's a great question. And hopefully I'll see you, Stephanie, at the LPHA conference right now. But yes, we are. I mean, we have sent out a survey to our local public health to find out from the cost and capacity what kind of support they need, how they'd like to unpack the cost and capacity in relationship to the foundational public health responsibilities. So wrapped up in that is also work and education around what the foundational responsibilities are, how they are the same, really high level as the previous framework that we were using in Minnesota. And we are getting out, Stephanie, so email me and Linda Kopecki. We're getting out and doing that work with local departments of health, community health boards, and then some, really just wanting to know what you guys need to help make that transition and help translate the framework to the work that you're doing and to your partners within your area. And we're doing that across the state.
Thank you so much, Kim. And then I see there's also a question to our state and local partners who presented. Did you create your own assessment tools or use FABs? And I assume that this is referring to the capacity and cost assessment. If I'm wrong, please put that in the chat.
This is Sarah
Joan.
from Oregon. Oh, sorry. I'll put my email in chat in just a minute. Oregon, we created our own since I don't think the national one existed back in 2016. We worked with a contractor to develop that assessment, and you kind of see different iterations of that assessment being developed and used by other states.
This is Kim. We developed ours, our own, with the University of Minnesota. They actually put it all together for us, but we had it based on our previous framework that we were using before we shifted to the national framework.
And this is Joan from Wisconsin. We use the national tool that was released in March.
Yeah, and I'll add just real quickly on that front, the value of utilizing the national tool is that we do have plans. We have a new system that we're currently building called Public Health Lift, which is a repository for data from national assessment work. And so we're looking at how we can then take some of that data from the capacity and cost assessment, those that are using the national tool, and put that de-identified, of course, into this public health list system to use for research, but to also compare and benchmark across the country and to make a case for continued infrastructure funding. It also supports the back-end calculations on the workforce calculator. And Rena, I would ask you to add anything else that you might want to in the chat or come off mute about the value of the national assessment tool. Let's see here. Joan, can you speak a little bit about how you intend to use the results from your capacity and cost assessment work?
Sure. A little fun fact for everybody, and many of you might be able to identify with this. In Wisconsin, we are ranked 42nd out of 50 states with the lowest budget funding for public health. And we're currently back in 2021 investing about $17 per person when compared to the median investment of 36 in the United States. So one of the budget asks we've had for a number of years through our state association is funding for governmental public health. And we've never had any data. So it was just gross estimates of what we thought we'd need. So part of what we're wanting to do is really be able to articulate where investments are currently going, and then what is that gap for full implementation of FPS. The other thing I also would want to share is it's definitely an opportunity to take a look at where are there opportunities for further sharing services in terms of gaining efficiencies as well as expertise in areas and fields that a local health department standalone may not be able to do alone, but with combined other health departments may be able to do together. So it's really a combination of looking at where are there capacity opportunities as well as then looking at funding.
Great. Thank you, Joan. And I'm looking at my list here, and I think we've covered all the questions either within the chat or through the open Q&A. And I know we've got about 4 minutes left. And so, a response to Jason's question. Let me go back up here. So there are a lot of health departments just getting their feet wet with the FPHS, and it might be worth discussing what adopting the FPHS practically means for systems transformation versus how most health departments approach public health today. And Rena, not to put you on the spot, is that something that you would be willing to address?
Happy to address it, but I wonder if our presenters can share from their perspective, maybe just in a minute or two. Good to hear that.
So what adopting that? Yeah, go ahead.
I was going to ask if you repeat the question.
Yeah, that's what I just started to do, Kim. So, so there are a lot of health departments that are just getting their feet wet with the foundational public health service model. So what does adopting the FPHS practically mean for systems transformation versus how most health departments approach public health today?
Thank you. I mean, I think Sarah probably has the most longevity in this work, but for us in Minnesota, we have
I think we lost Kim for a moment. Sarah, you just came off mute. Did you? Oh, here we go. Go ahead, Sarah.
Okay, hopefully. Yeah, hopefully I'm not speaking over Kim. I really wanted to hear what she had to say. I think for us, what it means practically is that as an entire system, we have some collective vision of the direction that we're trying to go. So, public health in our sort of categorical focus on the emergency structures for funding things, we're always in response mode. Practically, public health modernization puts us in a very forward-looking mode. It's not something that you can accomplish in a 2-year funding cycle or even in a decade. It really is very long-term work, and it sets our system up to be very strategic and have to work together and know what those long-term goals are. So every decision we make along the way is toward those long-term goals. And I think that's been the biggest benefit for us in Oregon.
Sorry about the mute out there, folks. A big amen to what Sarah just said. But we are, I think it's trying to shift this whole system doesn't happen quickly. And so little by little in each of the areas of our framework, we are looking at, okay, who is doing what? We don't have clarity in many of those cases on roles and responsibilities. So that's the first place we're starting. And then we're talking about, well, we hope to talk about, okay, so what does it look like for us in infectious disease to do community partnership. What does that mean? What are those activities? How do we measure? What are the measures that help us understand that we're making progress on any of these things? We are just starting with all of that work, and we anticipate it will take us a long time to get there, but it's an iterative, evolving process. And as Sarah said, this is going to be work for generations that come behind me. And it's a very different way to think about how we do public health. But we all think it's really worth it.
And this is Joan. I'll just kind of weigh in and reinforce what you've heard Sarah and Kim share. But I think really it's decades of work ahead of us, and I think having common language and language that we all are using as we communicate what is public health and the value of public health is really important. And I think it's a slow process, finding opportunities in terms of partnerships and expanding those systems and being able to take our elected officials along the ride as well in terms of why their investments in things like systems, which is maybe not having the same kind of clear outcomes as individuals, is of value and of greater value when you're trying to improve the health of your population.
Thank you all. And I would add too, in its simplest form, I know in my work in local and state in Ohio, what we really appreciated about the framework is it gives you a place to start. We're doing so much work and it creates some level of focus and making sure that we're doing those minimal foundational capabilities and we're addressing or the minimum package, the foundational capabilities in the foundational areas, and that we're doing it really, really well. And so that focus has been very helpful, I know, in Ohio as well. All right, so with that, if we could advance the slide, I know we're at 4:02, so I want to thank everyone for hanging on just a little while longer. If you need to log off, we understand. We'll be following up via email. But I would, before you log off, if you have a moment, we are thinking about and exploring the idea of other webinars on the foundational public health services. So if you have ideas for content or areas where you want to dig a little bit deeper, please feel free to put that in the chat and we'll take that into consideration as we're planning. We also have an evaluation, and I know that Lydia will be putting that in the chat. We'll also send that post-webinar via email, but we do appreciate and use the feedback. So if you could take just a minute or two to fill that out. We've also included the question about future content as well, so you'll have a chance to share more ideas there. And then we've also included the general email to our website, and then also our general email to the Center for Innovation team here at FAB. So again, on behalf of FAB, I want to thank you for being here. Thank you so very much, Joan, Sarah, and Kim, for being here with us today. And to all of you who took time out of your day to join us, have a wonderful afternoon.